Hello, good evening. My name is Dr. Jessica Burgers, and I am a fellowship-trained breast surgeon here at Holy Cross Health. I am excited to be a part of this October Breast Cancer Awareness Month series, and I hope you'll have a chance to listen to some of the other lectures. Breast cancer treatment takes a team of physicians, and as a surgical oncologist, tonight I want to share with you some of the options in the surgical treatment of breast cancer. Often, the first step in treatment of breast cancer is surgery. However, there are some scenarios in which we know treating a tumor medically first, such as using chemotherapy or endocrine therapy, can optimize surgery at a later step. In order to treat breast cancer, surgery must both address the tumor in the breast, as well as the lymph node system that drains the breast. This lives underneath the armpit, or what we refer to as the axilla. So let's first talk about the breast. Surgery on the breast generally takes one of two forms, either a mastectomy, or removing the entire breast, or a lumpectomy, removing just the cancerous tumor within the breast with a rim or margin of normal tissue around it. Which option is best for a patient is based on their own unique cancer details, such as staging, location, genetics. Fortunately, the data shows equivalent survival results with both surgeries. There are over 3.5 million women with a history of breast cancer living in the U.S. today. That is a lot of survivors and a lot of thrivers. And what we have learned from having all of these women go through treatment is that there is a real psychological impact to the aesthetic outcome of a breast surgery. As a result, there has been a lot of innovation in trying to improve the cosmetic outcome without sacrificing a cancer cure. I want to talk a bit about some innovations in the lumpectomy and in the mastectomy. When it comes to developing a better lumpectomy, one simple technique is a hidden scar. Hiding scars can be done around the areola or in a natural body fold, such as under the armpit or below the breast. More advanced lumpectomy techniques involve combining plastic surgery tissue advancement techniques with cancer surgery principles and what has become known as oncoplastic surgery. For example, in a traditional cosmetic breast reduction, tissue is removed and then rearranged to create a smaller, more lifted breast. Using this framework, we can remove a breast tumor with a wide margin, use tissue repositioning to achieve an excellent cancer operation with an appealing aesthetic outcome. The other breast can then have surgery to be made to match so that a woman appears symmetric. Mastectomies have also made improvements. Mastectomy, for example, the technique of a nipple-sparing mastectomy. In a traditional mastectomy, the tissue is removed, including the nipple, by an elliptical incision. We now understand that the most superficial part of the nipple can be preserved in certain women, so that when a mastectomy reconstruction is performed, a woman will have her natural nipple. There's no need for tattooing or additional procedures. Her breast, when reconstructed, will appear very similar to her breast before it was removed. Initially, nipple-sparing mastectomy was reserved for women with smaller breasts. The concern was that women who have droopy, or what we call ptotic breasts, was the potential adverse impact on the blood flow going to the remaining nipple tissue. However, it is now possible to stage a nipple-sparing mastectomy. So first, a breast can be reduced. The nipple can be repositioned into a more optimal place, allow healing to the nipple, and then come back for a mastectomy at a later date. This technique is most often used in women who are choosing prophylactic surgery, such as those that carry a genetic mutation. Techniques are also being implemented to improve the outcomes with the lymph node portion of a breast cancer surgery. One of the dreaded side effects of lymph node surgery is lymphedema, or arm swelling, and this can cause significant debility in the women who develop it. Fortunately, breast surgeons have sought to minimize the risk of lymphedema, and we have become more selective in the lymph nodes that are removed, honing in on those most likely to harbor cancer. This is done by injecting a tracer or a dye into the breast to identify the first lymph nodes to drain the breast, or what we refer to as the sentinel lymph nodes. We can evaluate those lymph nodes in real time in the OR to see if there is any evidence of cancer cells. We have much more stringent criteria in deciding which patients will go on to have many lymph nodes removed, or what is referred to as an axillary dissection. In those patients whose cancer necessitates a more extensive lymph node procedure, it is possible to try to preserve the lymphatics or lymph nodes that drain the arm by using a different dye to separate those from the ones that are draining the breast. And this technique is called axillary reverse mapping. I am really excited to be one of the only sites in our area of South Florida participating in the National Cancer Institute Alliance Axillary Reverse Mapping Trial. And this is an investigation happening throughout cancer centers across the country to look at that axillary reverse mapping technique to see if it will, in fact, minimize the risk of arm swelling after lymph nodes are removed. I cannot emphasize enough the importance of the multimodal treatment of breast cancer. I am a surgeon. Surgery is a key component, but the great outcomes and survival rates that we now have with breast cancer involve a combination of surgery with medical treatment and radiation treatment. I hope you will join us for some of the other lectures in this series to learn about some of those other modalities. And I will now take questions.
Okay, so one of the first questions we have is, has the downtime or the recovery time improved for some of the surgical advances you discussed earlier?
Yes. For both types of surgery, we have significantly shortened the length of stay that patients are in the hospital. Specifically with a lumpectomy, that is an outpatient surgery. You go home the same day. Oncoplastic surgery, such as a breast reduction, is also an outpatient surgery. So by combining a lumpectomy with a reduction, the patients still go home the same day. Mastectomy is typically one night in the hospital, and patients go home the next day. We always take into consideration factors such as other comorbidities that may prompt a couple nights stay, but I would say most patients stay less than one day.
Okay. We have another question. Does reconstruction happen immediately, or is it a second operation down the road?
So another one of the advances in surgery is that we have become more comfortable with initiating the reconstruction process on the same day as the initial surgery. And so, for example, with a mastectomy, after I finish removing the breast tissue, I am working in tandem with the plastic surgeon who begins the reconstruction process by starting to set the framework for what will be the final reconstructed breast. This is typically a temporary implant device, or what we call a tissue expander, but this process begins at that initial surgery, and so this again minimizes the number of procedures as well as length of stay.
And the question is, does insurance cover reconstruction?
Yes, insurance does cover reconstruction. Thanks to a lot of efforts by a lot of very inspiring women, there is the Women's Health and Cancer Rights Act Act of 1998, which is a federal law that says insurances are supposed to cover women's breast reconstruction after having a cancer operation. And this includes both mastectomies as well as lumpectomies. As I mentioned before, we know that the cosmetic outcome has such an important psychological impact for women who are going to live many years beyond their cancer surgery. And so, as I mentioned, there were women that fought hard to make this a federal law to allow women to have the reconstruction they deserve.
Okay. And then the lymphedema that you mentioned earlier, can you talk a little bit about how that's treated at Holy Cross?
So lymphedema, as I mentioned, is arm swelling that can develop after lymph nodes are removed in an operation. Here at Holy Cross, we do have a specialized physical therapy department that includes oncologic physical therapists who have had additional training in how to manage lymphedema, as well as maybe some of the other range of motion restrictions and things that can come after a cancer operation. Lymphedema is one of the biggest things is prevention. And so that involves setting the patient up with the physical therapist to educate them on ways to minimize their risk for arm swelling and give them education about things like lymphatic massage and wearing lymphedema sleeves. But as I mentioned, it takes a team, and so I am so grateful that we have the support of those physical therapists with their extra level of expertise to help manage the patients, identify lymphedema early so that it does not become a significant problem for patients.
And then the axillary trial that you mentioned, who can enroll in that? Can you talk a little bit more about that?
So there are specific criteria about which patients could be considered for the axillary reverse mapping trial, but it is something that we look at for every patient who is going to be undergoing any type of lymph node procedure. Specifically, it is designed for patients who are undergoing mastectomies or patients who have maybe more locally advanced breast cancer that are undergoing lumpectomies. The idea with this trial is to try to, as I mentioned before, identify the lymph nodes that are draining the arm so that they can be preserved, or if in a certain situation we do have to take those lymph nodes because they are compromised, we can then try to reconnect the lymphatics that are remaining so that the lymphatic flow can be reestablished. But if a patient is seeing me in the office to talk about their breast cancer, I look through the specific criteria from this national study, and we always try to consider enrolling every patient because I think that it will have a large impact.
And then just any final key takeaways you'd like to leave us with?
Well, it is Breast Cancer Awareness Month, so get your mammogram, and I know that a lot of the events that go on this month have been shifted to a virtual setting, but things are still happening, and we are still, again, as I said, celebrating our survivors and thrivers. So please look for making strides and things on virtual platforms, and again, and see the rest of our team on this Facebook Live series.